Hi everybody, little Scotty Moss here again. Thought I'd talk about mitral valve anomalies because it's probably one of the most common reasons we do a pediatric echo. I drew a little picture here of like a 4-chamber view, and I wanted to draw some of the anatomy of the mitral valve so you have an idea of what's going on here. So the mitral valve has two muscular attachments called the papillary muscles. You have an anterior and a posterior, and then those muscles turn into what they call Chordae tendineae, which is, they're very thin, they're like tendons is basically what they are, and they go to the mitral valve and help support it. And when the mitral valve closes, the papillary muscles contract and push the valve leaflets closed. And that's basically, when they contract, they pull the leaflets open, and then as the blood leaves the ventricle, it helps to push the valve closed. Anyhow, so this is obviously the left atrium, and this is the right side. So RV down here, and your tricuspid valve is here, right? And then obviously the mitral valve right here. Okay. Now, the reason why I wanted to draw this is because one of the things that we see a lot of is rule out mitral valve prolapse. A doctor will hear what they call a click, which is an extra heart sound. It sounds exactly what they describe it as, a click, and they assume that there's something wrong with the mitral valve when they hear that. Now, mitral valve prolapse for years. Now, I started doing echoes in 1984. Oh my God, I can't believe I'm that old. But anyways, when I started doing echoes, this is especially true in women. I don't know why it was that way, but I'm assuming it's because it was harder to describe chest pain for women than it was for men. Men usually had specific symptoms that were obvious to, a heart attack. So men would complain of pain going down the left arm, and then obviously the chest pain, sometimes left jaw, left side of the neck even. And women have a little bit more of a vague description sometimes of chest pain, so it's a little harder to determine. So a lot of times what would happen is they'd do the standard treadmill, and they'd put them up there, and the women would come back with no abnormalities on the treadmill, hopefully. And then the next step would be an echocardiogram. And for years it seemed like every woman who walked in for an echocardiogram left with a diagnosis of mitral valve prolapse. It got so bad that I think it was the AMA, American Medical Association, or maybe one of the other associations, decided that if we were to take these numbers, the percentile of people that were leaving the echo lab with the diagnosis of mitral valve prolapse, it would be considered at epidemic proportions. So something was not right. And they knew it, and they had to reevaluate what truly was mitral valve prolapse. And they did so. I do believe it started in the 90s when they started to look at it again, and then by the late 1990s, early 2000s, they had a better idea of what we should call mitral valve prolapse. And I'm going to erase some of this and kind of give you an idea. Okay, now this would be a normal closure of a mitral valve. The valves coapt and they meet in the middle. Everything is wonderful. We all dance around and laugh. It's great. And there's no leakage, usually. Every once in a while, some people will have a little bit of mitral regurg for no real significant reason. It's just there. Don't panic. It doesn't mean the end of the world. Some people live their whole lives with a touch of mitral regurg, so it's not that big of a deal. This is normal, what a normal closure of the mitral valve looks like. Now let me show you the next step. Okay, so for years they would call this mitral valve prolapse, when the truth is this valve does not prolapse. It is a flattening of the valve, which is what they came up with as a diagnosis. I'm sure they had a more, dignified way of putting that, or doctor speak, if you know what I mean. So, but it became more of a diagnosis of flattening of the mitral valve, which didn't mean regurg. They also said that to actually have the diagnosis of mitral regurg, you did have to have some MR. So let's look at what mitral valve prolapse really will look like. Okay, so let's take a look at your mitral valve prolapse here and what it actually does look like. You can see, let's make this a little bit blue and a little bit red and a little bit yellow, and wow, look at all that color, and I screwed up because there's no blue left, but anyways. You can see that the posterior leaflet of the mitral valve is actually, it is obviously prolapsing into the left atrium. Okay, now this is no longer flattening, this is true prolapse. Okay, now it can happen to either leaflet, but for some reason I think it seems to happen to the posterior leaflet more often. I don't know if that's just me, but that's what my experience was. So it could be either way, don't hold me to that. And there's always some mitral regurg. The significance of the mitral regurg is, depends upon the doc calling it. I'm not a big believer in all the specific mitral regurg testing for, shaping or tracing the mitral valve regurg jet, and then tracing the left atrial size, and then determining how, what the difference is. Also the velocity, and all the other things that people used to trace the velocity and say that, oh, there's severe mitral regurg because the velocity is 5 meters per second. Well, the truth is that just means that there's a small prolapse and that the velocity is high because the ventricle is good. So we got rid of those because that's not the way to tell how severe a mitral regurg jet is. The way to tell a severe mitral regurg jet is the width of it. Okay, so if you have a significant width, with very turbulent flow, all different colors, and it's obviously, it aliases a lot, and look up aliasing if you don't know what that means. I'm not going to explain it. It'll take another 6 weeks. So this would be true mitral valve prolapse. This would be severe prolapse because of the amount of the regurg, and also the fact that the valve doesn't coapt completely. It doesn't touch, in the middle. There's a significant leakage there. Now, what that will cause is significant left atrial dilatation. That will be the first thing. And then because there's blood backing up in the lungs, because all this blood is flowing back from the mitral valve, eventually the RV will also dilate, and even the right atrium will dilate. So both of these will dilate too. And then eventually the RV and the LV can fail, and it's a significant problem. This valve would have to be replaced because of it. Now, depending upon how old the child is, and this is the other thing, this is most mitral valve problems that are significant are found in adults, but we do see the occasional child that comes in that has a significant mitral regurg, or they can have some anomaly that I'll show you in a little bit that will cause that problem. So let's get on to those. Okay, here's a quick drawing of pretty much the same thing I just drew. Now this would be a pediatric view where the ventricles are on the bottom here. You can see, even though it looks like the valve is, this is kind of overdrawn, this looks like the valve is prolapsing a little bit, but the truth is that in this area here and this area here, the valve actually is pushed back pretty hard and it looks like it's prolapsing, but the truth is that's a normal coapting valve. Whereas a prolapse valve to the right here, you can see how this valve doesn't really meet with this valve, and there's going to be regurg here. So that's a true prolapse valve. So anyhow, oh look, I drew a frowny face on the left side. Oh, that's interesting. Anyhow, that's a good picture describing it. Okay, and then we'll get on to some other ones here. I'm sorry, folks, this one might be a little bit longer than normal because mitral valve prolapse is so prominent in the pediatric world. So on the left, you see a normal looking heart with normal coaptation of the mitral valve. You can see how it looks there, and it's not prolapsing. It's in pretty good shape. And on the left, you can see a significant difference. There is true prolapse here, and then they'll say, you know, blood leaking back into the left atrium. These little arrows represent the regurg. So this is a true mitral valve prolapse. You can see how badly those leaflets back up. For a long time, we used to draw kind of a line right across where the atrium and the ventricles met, and if it prolapsed more than 2 millimeters back, it was considered true prolapse. I know that doesn't seem like a lot, 2 millimeters, but in a case where you're measuring it on a 2D image, it's you can notice it, you'll see it, so we'll get on. Okay, this is kind of a short axis view. It's kind of tilted a little bit, so it's a little bit different, but it does show you what the mitral valve looks like when it's closed. And you can see that there's, you know, basically an anterior leaflet here. I forgot to put my pen on, so this would be the anterior leaflet, this would be the posterior leaflet. They do section it out. I cannot remember right now what the different sections are, but this is a section, this is, you know, it basically I think is 6 sections, but that don't hold me to that. That's been a long time. So the mitral valve itself, that's what it looks like when it's closed. Okay, quickly just show you this. I had this on my pictures, and I wanted to show you. This is how mitral regurg most of the time is repaired. If they can repair it rather than replace the valve, that's a much better deal. You don't have to worry about blood thinners or anything like that. This is a sewing ring. There is a official, the guy who invented it, there is official name for this sewing ring, or it's basically, when they sew it in, it gives the valve extra support, and by doing that the annulus kind of stays a little bit more stiff, and then the valve ideally doesn't leak as much. I've seen it work very well, and I've seen it not work so well, so it just depends upon the patient. Everybody's a little bit different. The valve will still leak a little bit, but not near as much as it did before, so that's a good thing. Okay, I wanted to put this one in there. And one other thing before we go on any further. These drawings on this particular one, which I'm probably using illegally, I'm sorry, my Mayo Clinic, but Mayo Clinic has some of the best drawings in any kind of problem that you want to look up. They are just fantastic at putting together anatomical slides, you know, with the full cut of the problem in a pathology cut, and then someone who is a fantastic artist goes and draws it like this, and then they compare it to an echo. Now the thing here, this is mitral stenosis with pregnancy, which is rare, but you do see it. So you can see the thickening of the mitral valve here and here. Then you see all the little dots here. That's also kind of in the leaflet. And also up here, I'll give you a little old guy information. As you can see, that mitral valve looks like it's not opening all the way. There's only a small opening right here. There's also one other thing that I'll give you a hint about that, like I said, was an old guy hint. The anterior leaflet of the mitral valve will look like a hockey stick. So if you can imagine a hockey stick, and the reason why I'm retired right now partially is because I was a hockey player at the semi-professional level, and I'm pretty beat up because of that too. So anyhow, it has that look of a hockey stick. So kind of a not a perfect way of figuring out that there's mitral stenosis, but that's one way to do it. Now, children rarely have mitral stenosis, but it does happen. I've seen babies born with mitral stenosis, so it does happen. So you have to keep an eye out for it. That's why we sample each valve, to make sure that there's no stenosis anywhere. Alright, a quick look at this. This is showing a normal, sorry folks, I keep doing that. A normal mitral valve, obviously right here. When they zoom in on it, you can see how it closes real well. And then this is a prolapsed mitral valve, and you can see right here where the leaflet is prolapsing. Now usually the reason why it's doing that is because there's a torn Chordae, which is kind of outlined here, I do believe. And the Chordae, remember, those are the little tendons that attach to the mitral valve, can be torn for a number of reasons. The paper I actually wrote to get out of school was on traumatic Chordae tears in patients. It used to happen quite a bit when we didn't have to wear seat belts and we would slam our chest against the steering wheel. And what would happen is the cords would tear, or the papillary muscle would tear, and you'd have this incredible amount of mitral regurg. Patients would come in extremely short of breath, sometimes bent way over to try to breathe. It was an emergency situation, and remember, at that point, echo was in its infancy, and it was mostly just M mode, and trying to figure out what was going on was hard, and then getting a surgeon. Unfortunately, a lot of these people didn't make it. Okay, here's a view of, sorry, a long axis view. And this is showing that line I was talking about before that you draw from, the annulus of the aorta and the mitral valve where it meets to the papillary muscle connection, or I'm sorry, the myocardial connection to the atrium. And if you draw that line, if it goes back more than 2 millimeters, let's say this was 2 millimeters, let's say right here, then that would obviously be prolapse. This would be, a normal valve coapting. So, okay, the reason why I put this one in here is mainly for one thing, and that's this section right here. Occurs in about 5% of all adults, so it's a pretty common thing to have. You have a floppy mitral valve caused by congenital anomalies or degenerative myxomatous changes, Marfan syndrome, which Marfan syndrome I'll explain at a later date. Asymptomatic, atypical chest pain, benign arrhythmia, small risk of embolic stroke. Mid-systolic click and late systolic murmur, that would be the mitral regurg. Prognosis is good, so usually it's not something to worry about. Alright, the only reason I put this one in here, this is a normal valve, but I wanted you to, they call remember I was talking about the different sections, they call them lobes. But what I want you to really pay attention to is how many cords there are here connecting the mitral valve to the papillary muscles. There's quite a few. So if any one of those cords tear for any reason, I mean, you were a kid and you fell out of a tree, guess what? Sometimes that'll do it. But it's important because the next thing we're going to cover, I want you to remember how there's two papillary muscles and all those cords attaching to the mitral valve. Alright, quickly I wanted to show you this picture. This is a shot of something that is a congenital defect that you need to recognize when you see it. This is a long axis view of what will most likely be, in fact I know it is on this one, a parachute mitral valve. Now a parachute mitral valve is explained by, if you were to look at a mitral valve, I'll draw it over here on the side, and it's closed. All the cords will go to one papillary muscle, and the other papillary muscle will be abnormally small, and there won't be anything attached to it. Or if there are, there may be one, and it may not even connect. It's hard to say. But it causes the valve to open kind of in a weird way, and it looks like a parachute when it's opening. So that's what they call a parachute mitral valve. Alright, so here's another drawing of a parachute mitral valve. This is kind of a modified 4-chamber view, and I just wanted to show you that, here's what looks like is the anterior leaflet, which is very long, posterior leaflet, which is short, and it appears that the papillary muscle kind of starts here, a little wider maybe, and that the chordae all attach this way, up into the mitral valve. So you have one decent papillary muscle, and it's causing this parachute mitral valve. This is very interesting. This is something I only saw a few times in my 33-year career. This is a double orifice mitral valve. So you have two papillary muscles that basically are separate, and they create their own, well, the papillary muscles don't, but by so doing they actually produce what looks like two separate mitral valves. And you can, a child can survive with this as long as they don't get stenotic and as long as they don't leak a lot, but most of the time they do leak. So, but it is very interesting looking, and if you see that on your short axis view, obviously you're looking at a double orifice mitral valve. Okay, this is what you see sometimes in a traumatic problem with the mitral valve. These little, if you look on the upper left, there's little kind of cords all over the place. They're here, and they're flopping around. You can see them here too in the 4-chamber view, right here. There is a significant amount of mitral regurg in several views, I'm sure. This could be a Chordae tendineae tear, which may have been caused by a traumatic incident. Any trauma to the chest can cause this, so anything, motorcycle accident, those kind of things. Sometimes you see them in kids because we have kids that ride motorcycles. So anyhow, this is one of those incidents where you see these Chordae tendineae tears, and they are flopping around on the ventricle, so you'll see them. Alright, last slide. I know, thank God. This is truly a mitral valve prolapse picture, and I wanted to put this up last to give you an idea. This is what prolapse looks like. I don't want you to think that, prolapse is just a straight line going across. That's not prolapse. Okay, prolapse is when it really drops down like this. That's true prolapse, and almost always there'll be insufficiency. So that's when you look at prolapse and you say, okay, this is true prolapse. Now, a lot of people, like I said before, will come in with a diagnosis saying, about 10 or 15 years ago, my doctor told me I had mitral valve prolapse. Well, because the criteria has changed now, they may not have mitral valve prolapse anymore. And try to explain that to them. It's very hard. But anyhow, in children, again, not as common, but it is there, and it is one of the main reasons why you'll do echoes in children. I hope you enjoyed this. I'm sorry it was so long, but there was a lot to cover. So have a good day.